I think it was something I always wanted to do, even before I became a medical student. I thought that a woman probably would want to see a woman if she had gynecological issues. And at that time, there really weren't very many women, certainly no women role models in gynecology. And so I thought I'd go into it and change all that.
Hello and welcome to GPs Talk Cancer, brought to you by Gateway C. I'm Dr. Rebecca Leon and I'm joined by Dr. Sarah Taylor. We're both practicing GPs and GP leads for Gateway C, and in this podcast we share our clinical experiences, reflections and practical insights to support earlier and more confident cancer diagnosis in primary care. So before we begin, a quick reminder. Although anyone may find this podcast interesting, it's designed for primary care health professionals. All patient cases are based on real clinical experiences, but are fully anonymised with no identifiable information. Gateway C is a free early cancer diagnosis resource funded by the NHS and based at the Christie NHS Foundation Trust. So today we're going to be sitting down and chatting with Professor of Gynecological Cancer Surgery, Emma Davidson, to discuss endometrial cancer. Welcome, Emma.
Thank you. Good morning.
Thank you.
Lovely to have you on this lovely spring day.
Absolutely.
Did you get here okay?
Yeah, absolutely fine.
Easy peasy?
Easy peasy.
I know. And isn't this a lovely new studio that we have?
I mean, I don't know about the newness, but it's absolutely beautiful.
It's lovely, isn't it?
I know. We do like working here. And how are you, Sarah?
I'm fine, thanks. How about you?
Yeah, good week.
Are you going
so
shopping
far.
in the Chinese supermarket after
Oh, yeah. So next door is a Chinese supermarket and they have like live stuff there. And I'm quite fascinated where they pull out eels and crabs and things.
Really?
So I sometimes drag Sarah there to get our
Have a
dinner.
look. Yes.
Promise there'll be no live crabs.
No. No.
So today we're going to be talking about endometrial cancer, which is your area of expertise.
What is your
really.
research?
I mean, I do a lot of research into endometrial cancer, but the main focus is on screening, prevention, and early detection. So trying to develop better non-invasive tools for screening and diagnosing endometrial cancer.
Right, okay. So what sort of things are you looking
A
at?
urine test.
Okay. Oh, fantastic.
A risk prediction calculator.
Yeah.
Vaginal swab. So essentially anything that can help us to triage women for rapid referral when we think they're at high risk of endometrial cancer, or to safely reassure them in primary care.
Oh, fantastic. That would work.
That'd
So
be
almost,
really good, wouldn't it?
almost a step away from that we go for an ultrasound as
Yes.
our first line.
Yes. So the idea that the ultrasound might be part of that sort of
Yeah.
clinical pathway, but hopefully it would help us to avoid all the invasive diagnostics. So the hysteroscopy and the biopsy, you know, if we could prevent the number of people having to have those that currently
Yeah,
do,
absolutely.
then that would be great.
Yeah, yeah. And because I think you were saying, weren't you, that hysteroscopy is one of those things that is can be very painful and unpleasant.
It can be really traumatising. So, you know, a lot of people go through it without any problems. So I don't want to over-dramatise it. You know, some people don't feel any pain. Some people just get on with it and it's all fine. It's a very quick procedure after all. But some people find it really very difficult, very uncomfortable, all the way up to excruciatingly painful. And of course, if we're doing a lot of these procedures for people who are not actually at high risk of endometrial cancer, then that feels like a shame, really.
Absolutely.
So it's
yeah.
how can we first of all, can we make hysteroscopy more pleasant? Are there ways that we can improve the experience for women? But secondly, can we avoid having it in the first place if we don't need it?
Yeah, sounds a little bit like I do a coil fit clinic, and that's again is something where some women find it really uncomfortable, and some people just sail through.
They
the
really
whole
do,
thing.
and it's so surprising when you've had
Yes.
people that find it uncomfortable to have someone that's literally not flinching.
Yeah.
and you think, wow.
and is it the same? I know with the coils that there's a huge amount of misinformation out there, and poor information on social media about how painful things are, what is actually done. Is it the same for hysteroscopy?
I mean, I think it is. So there are lots of groups that are really trying to support women, but, you know, sometimes they're talking about the horror stories associated with hysteroscopy and biopsy. So there's the campaign against painful hysteroscopy, which has gathered a bit of a momentum, charting women's usually bad experience of hysteroscopy, and then campaigning for change. I mean, I'm all for offering women a choice of different analgesias and anaesthesia to undergo these procedures, but we don't want to scare women, a lot of whom will actually just breeze through it. And we can't really predict. That's the problem.
Yeah,
we don't know
that's
until
what
we
I
try
find.
it.
Yes, and that's what I find is in the.
I mean, and what's interesting also with the younger patients where social media is really their go-to if they're being told it's going to be painful, if they're told it's going to be uncomfortable, they'll almost come in frame of mind saying, this is really going to be unpleasant.
Absolutely, and very anxious and therefore not relaxed in the first place. So, yeah.
So how would you, I think we're going to cover this anyway, but how would you recommend we counsel patients in primary care? What can we do to support that?
I mean, I think it is really important because a lot of times we now have these one-stop postmenopausal bleeding clinics where women would turn up with the symptom and then go through the full range of investigations right there and then. And I think if they're not expecting it, it's not part of what they thought was happening that day, it can be quite a shock. So I think having some basic idea of what to expect, that they may have a camera test, that they may have a biopsy taken, and that they might wish to take some paracetamol or Brufen if they can take it before they come to the appointment, that they might wish to bring somebody with them, and perhaps not to have planned anything stressful for the rest of the day, can really help.
Yeah. And what resources would you direct them to? Presumably there are some good resources out there.
I mean, there are some excellent resources on the Royal College of Obstetricians and Gynecologists website, so some patient information sheets and some clinician resources as well.
So maybe we can add that to our show notes that people can maybe use.
Yeah, I'm just wondering whether when we've got letters that we give out to patient or texts that we send out when patients are sent on a suspected cancer referral that are standardised, certainly in Greater Manchester, I'm just wondering whether we should add the hysteroscopy leaflet to anybody who's on a suspected endometrial cancer referral, and at least, even if the GP hasn't had that chat, at least if they've got something that says this might happen, and then if somebody rings them to give them an appointment, they can ask about it, can't they?
Yes, absolutely. I think that's a great idea.
Yeah. That's what I'll put that on my to-do list for this week.
Nice.
But I think we should be telling patients whatever is going to happen next. So if they're going to be going for an MRI scan, if they're going to be going for, I remember for prostate, I know that's completely not your area, but if they're going for truncal biopsies, which I know has changed now to MRIs, it was always really important to say this is what's going to happen next.
Yes.
And even if we're sending a patient to a suspected cancer clinic with a breast lump, we should probably be telling them where.
Although I think it's difficult, isn't it? Because you and I spend a lot of our lives doing this, so we know what to explain to people, how to explain what might happen. And we've got a reasonable idea as to what might happen, and things change, don't they, as well? So I suppose it, as well as that, it's having those resources to direct patients to, which somebody else can keep up to date rather than us. So I suspect there'd be a lot of my colleagues who would say, I have no idea how to tell somebody about hysteroscopy.
Or that's not my role.
Or it's not my role.
Yes, that's a specialist role.
But actually, if we can just attach a patient leaflet saying this might happen.
Can't do any harm.
That can't do any harm.
No.
So we've covered an awful lot before we started on what we're going to cover. That's good.
Yeah. Emma, how did you become a gynaecologist?
I think it was something I always wanted to do, even before I became a medical student. I thought that a woman probably would want to see a woman if she had gynecological issues. And at that time, there really weren't very many women, certainly no women role models in gynecology. And so I thought I'd go into it and change all that.
Excellent.
So you were trained in both obstetrics and gynecology.
Yes.
And then, do you do any obstetrics now?
No. God, no. Absolutely not. No, I did the full training to become an obstetrician gynecologist. And then I did subspecialty training to become a gynae cancer surgeon. And I also did academic training, which is why I do a lot of research now.
Okay. What's your job split?
It's about 50-50.
Right.
So you're still operating?
Well, actually, I've just stopped operating.
Okay. Just more recently?
Yes.
Yeah, great. Yes. Okay. I wonder if I see you again in 6 months, if you're missing the operation.
Yeah, it'll be interesting to see. So I've just been awarded one of these NIHR research professorships that pays my full salary.
Great.
And wants me to do lots of research.
Right.
So over the last 6 months, I've stopped my surgery.
Oh, wow.
Right. Okay. And how much of your research goes into primary care?
Well, I haven't actually branched into primary care yet. It's all at that kind of secondary care interface. It's developing these non-invasive diagnostic tools for endometrial cancer, but clearly the place for them to be used in clinical care will be in primary care.
Yeah, absolutely.
So that'll be the next stage of the research.
Let's talk about a couple of cases because it puts things into perspective and it's what we do best, seeing patients. So I'm going to talk about case one, if that's okay, which is a woman, let's say a 58-year-old, who has been on HRT, a continuous HRT for the last 5 years and is presented with vaginal spotting, taking a full history. It's been going on for about 4 to 5 weeks. No abnormal discharge, and she's actually not bled. This is the first episode since she's been on the HRT. She's got a BMI of 32, no significant family history, and examination findings were all normal. What do we do next? What do you think?
Well, she fits the criteria for urgent referral with suspected endometrial cancer. So we know that unscheduled bleeding on HRT is really common, but it's usually at the start of taking HRT. So for those first kind of 6 months, or if people change preparation, then we might experience some bleeding. But the fact that she's been on her continuous combined HRT for so long and now experiencing bleeding, that's a red flag for endometrial cancer. Of course, the risk factor profile is kind of plus and minuses, if you like. She has a BMI of 32, and we know that obesity is a major risk factor for endometrial cancer. But equally, she's on continuous combined HRT and has been for several years, and we know that's protective for endometrial cancer. So she has a couple of things either way, but nevertheless, this is a symptom that we should not ignore. We also have to think about other pathology, of course. So, an examination to rule out cervical cancer, or at least to take a cervical screening history, would also be relevant.
Okay. I want to question you saying, so the continuous combined preparation, you're saying is protective for endometrial cancer?
I mean, it actually is. So it's because it's got such a good dose of progesterone.
Yes.
And we know that probably the underlying mechanism between obesity and endometrial cancer in part relates to estrogen excess.
Yes.
So we think with obesity that you get aromatization of androgens to estrogen in fat cells, and that then causes unopposed stimulation of the endometrium because after the menopause, there's no cyclical progesterone. So when you're on continuous combined HRT, even though you're taking estrogen as well as progesterone, the progesterone counterbalances that proliferative effect of the estrogen.
So there's progesterone going around that wouldn't normally be there?
That's correct.
Okay.
And how important is it to talk about compliance? Because I do it all the time with women on the pill. If they have irregular bleeding, I will always ask if they've missed pills. I don't think I'm quite as rigorous in doing that with HRT, but I suspect people probably do run out and not get their repeat prescriptions in on time and this sort of thing.
I think that is important because clearly if they stop taking, then they're having essentially a progesterone withdrawal, which is the mechanism behind having, withdrawal bleeds on the pill, isn't it? So you take the pill for 3 weeks and you stop the pill. That's the progesterone withdrawal that triggers the withdrawal bleed. So it's similar, but if they are 58 and they've been on HRT for 5 years, it probably she probably has such a thin endometrium that she wouldn't experience this kind of bleeding if she stops it for, a couple of days. But yes, it's worth asking that question.
And I saw a patient a couple of weeks ago who'd come in for replacement of her Mirena coil, which was the progesterone component of her HRT. And for some reason, it was 2 years delayed. At which point I was thinking she's had unopposed estrogen now for 2 years. So what we ended up doing, we couldn't get the new coil in. I ended up giving her some oral progesterone, but sending her for a scan. Does that sound like a sort of reasonable thing to do?
I mean, I think you're right. So the coil is probably only releasing progesterone for 5 years, and I think it's only really licensed for 4 years in the context of HRT.
Yeah, I think it's just gone up to 5.
But nevertheless, if she's not experienced any bleeding, then that reduces the risk that there's a problem. And if you're about to put a new coil in, which you were, then hopefully that coil will start to work and reduce any issues going forward. But yes, I think you're right to certainly give the progesterone whilst waiting to put the new coil in.
And then
a scan isn't going to hurt.
That's what I thought, really. I thought, this is all a bit complicated, and it wasn't quite what I was expecting this afternoon.
When a patient comes in, a bit like my first lady, in an ideal world, should we advise them to stop the HRT when they do have unscheduled bleeding? But as you know, in realistic terms, they won't. Wrestling it.
I mean, that's the advice, isn't it? But yes, it's very difficult to get people to stop their HRT.
Exactly. So in an ideal world, they would stop.
Yes.
Until they're seen.
Yes.
Okay, that's fine. So when I was doing the HRT reviews last week, something I've learned that I'm not sure that you're aware of, that people who are on the contraceptive pill or the oral progesterone component, the HRT, and they're on weight loss injections, the GLP-1s, whether that's Mounjaro, Ozempic, Wegovy, etc., primary care need to be aware that the weight loss injections can slow gastric emptying, which can reduce the absorption of medications. So particularly with progesterone, which is protective with the estrogen, we need to increase the dose of the oral progesterone that they're taking. So, for example, if they're on the continuous combined regime, rather than taking 100 milligrams every night, that needs to be increased to 200 milligrams a night.
So we really need to be asking about that, because whilst most patients, if they're on it from buying something online or whatever, we get a notification. I don't think we get always. So I think it's a positive question you should be asking rather than just relying on it.
Well, we should be
being in
asking
your notes.
anyway, because they might be presenting with side effects, and people are embarrassed to tell us.
So if this woman on the HRT had been on for 6 or 12 months and wasn't overweight, what would your advice be then? Does that change? And how do we decide what the cut-offs for all of this are?
Well, the current guidance is that if they're over 55, that they have urgent referral for suspected endometrial cancer if they've been on HRT for 6 months or more.
Right.
But if they're under 55, then you have to use a bit of discretion about whether it's considering urgent referral or referring them urgently. So I think this case study, she was 58, wasn't she?
Yeah.
And she'd been on it for 12 months. So she would still count for urgent referral.
Yeah.
But it's these ones who are 51, 52, may not have been compliant with their sequential HRT, these ones that are probably having unscheduled bleeding, where we need to also weigh up things like risk factors.
So what risk factors are we looking for?
Well, obesity being the main one. So BMI as a measure. So I think if they have a BMI over 40, then that's considered a major risk factor for endometrial cancer, and they would kind of need urgent referral. Anything over a 30, so between 30 and 40, would be considered a minor risk factor. And then there are things about, how long they've been on their preparation, what type of preparation they're on, whether they have a family history, whether they've got type 2 diabetes, whether they've got a history of PCOS. So that these kinds of risk factors would increase your index of suspicion, which in turn would mean that you would send them for an ultrasound scan as the first line.
And where would you, because that's quite a lot of things to remember. I think there's the British Menopause Society. Have got
it's
some
an excellent flow chart, So I would recommend everybody downloads that and has that available.
I've got a question about BMI. I go curveballs. I'm kind of Dr. Curveball on this podcast because
Nice.
Is the actual calculation of BMI, is that being looked at? We obviously talk about weight being it, and BMI is the obvious one because it's weight and height combined. But is there now looking at waist circumference and other things as well?
Yeah, no, you're absolutely right. So waist circumference and waist hips, ratio is supposed to be a better predictor of the kind of obesity that increases cancer risk.
Glad you're not dreaming about that.
But I think in women, BMI is a good proxy.
Yeah.
It's about men having a lot of muscle mass, isn't it?
Yeah.
But women are getting the muscle mass
they
now.
are. They are.
We're encouraging people to build muscle as they get older.
Absolutely.
Core strength.
Especially post-menopause.
Yes.
Very important.
Yes. I'm going twice a week now. You'll be pleased.
Yeah.
My weight classes. Don't really like exercise. So I'm really working hard on it. Sarah does running, you see, so that's why she can do that. So I want to talk, we've talked about the risk factors.
Yeah.
Can we now, and we'll talk about family history in a minute because it's really interesting. Can we talk about the protective factors for endometrial cancer?
So clearly maintaining a healthy body weight, physical activity.
Yes.
So being regularly active is very, very good in terms of preventing endometrial cancer. And then things like having been on the combined oral contraceptive pill for a period of time as a contraceptive is very protective of future endometrial cancer risk. And then continuous combined HRT is protective. So as long as you've got enough progesterone, then that actually protects against endometrial cancer. It's when you don't have enough progesterone relative to your estrogen that it's not so clear. And of course, estrogen-only HRT, we don't give it anymore, but that is a major risk factor for endometrial cancer.
I don't think I've ever given estrogen-only HRT.
No.
Do you think
it's historic, isn't it? But it's in all the textbooks.
Oh, okay.
I guess it's about whether or not people have had their coil taken out and we're not aware of it.
Well, yes,
their
but
Mirena coil taken out.
Yes.
And we're continuing to give the estrogel, for example.
Yeah.
But yes, so long as they're on combined HRT.
Yes, I think this patient that I was describing whose coil was expired was on a gel preparation, and I think that when it was on repeat prescription, and I think what had happened is that everybody had presumed it was not really thought hard enough and realised it wasn't a vaginal estrogen, which we would give without progesterone cover.
Yes, we would.
But actually, it was an HRT estrogel rather than a. So I think that it was the gel that just. I think had it been a tablet or a patch, somebody might have thought again. And I don't know. This had gone on for some time, and I don't know. I'm not accusing other people. I might well have signed the repeat prescription as well without registering it. I think it's quite easy to do.
Yes.
And also women are taking more and more of the estrogen, aren't they?
Yeah.
Because they know that that's the bit that makes them feel good.
Yeah.
So if they're having 4 pumps of their estrogel or 8 pumps of their estrogel but are having a very small dose of their progesterone, then it's not going to be enough. That wouldn't count as, combined HRT because the counterbalance isn't going to be good enough.
And that's why we have to do these annual reviews in primary care to ask the questions. How many pumps are you having? What's the dose of progesterone that you're using?
Are you taking it?
Are you taking it?
Yes.
And the interesting thing now I'm seeing with progesterone is people actually, when they're coming off HRT, are actually saying, but can we carry on with the progesterone because it's helping with my sleep?
Oh, interesting.
So actually we're like, no. It's not licensed for that.
No.
But we have to look at when the Mirena expires, if they're on the right dose, because some of the other private clinics will give high doses of estrogen going up and up and up. We're a little bit unsure after about 100 personally. But if... and I want to ask you another question. This, again, is just something I'm interested in. Do you feel that the younger that you start HRT, because we're starting it now for perimenopause and things like that, do you think that higher doses are needed?
I mean, not necessarily. I think it's about the highest, the minimum dose that is effective, isn't it?
But do you think younger patients almost need a higher dose?
Yeah, possibly.
That's what I'm trying to say.
Yes, possibly. Because they are going from a much higher baseline, aren't they?
Yeah, maybe.
So if we start it post-menopause, they probably need a lower dose, don't they?
Yeah.
And as they transition, their requirements may drop.
Yeah.
So again, that annual review is really important because you can assess whether or not they still need their 4 pumps or if they can go down to 3 or 2 or 1.
Yeah.
So I think, yes, perimenopause, they need a higher starting dose to be effective to prevent those vasomotor symptoms and the brain fog and the sleep disturbance and so on. But as they get older, they probably don't still need to be on that higher dose.
I spoke to a patient yesterday who's taking a combined preparation but alternate days because she said that was...
So my mother, who's 82, bless her, she's like the poster girl for HRT.
Bless.
She won't mind me saying she's had a hysterectomy, so she's on estrogen only, and she just takes it 3 times a week. And I'm saying, I don't think it's doing much. She goes, it makes me feel good.
Nice.
So it's like, fine. And like
Why
the
not?
GP every year tries to wrestle it off her. And she's like, I know the risks. I'm going to still take it. Oral, she won't have any transdermal stuff. So oral estrogen,
Well, good for
3
her.
times a week.
She's informed. She knows what she's doing. Why not?
Exactly. So, okay, so let's talk about your case because this is an interesting one.
So this is a 45-year-old woman who comes in with irregular bleeding, suggesting, not on any hormonal contraception, suggesting that, is she menopausal? Is she, what's going on? But just an irregular bleeding pattern, having always had fairly regular periods. BMI of 34, so a bit raised BMI. And then on further questioning, mum had endometrial cancer in her 60s and also has an uncle who's had a colorectal cancer. I suppose there's quite a lot in this, but I suppose there's just, it's what we should do, what we should think, and how we should do if we remove some of those risk factors as well. Because I think if you've got lots of risk factors, it's easier, isn't it?
Yeah, and it's really difficult, isn't it? Because
Yeah.
that's such a common complaint,
Yes.
isn't it? Irregular bleeding,
Yes,
especially in the
totally.
40s.
Yeah.
So if we referred everybody with suspected endometrial cancer, we would flood the system even more than is currently flooded with all the unscheduled bleeding on HRT. So it's very difficult. And I think it's this younger age group where we really do need to think about the risk factors and whether or not that puts someone at an increased risk. So we need to think about the other causes of bleeding in that age group, don't we? So
yeah.
STIs, are they up to date with cervical screening? Is there any obvious cervical cancer? Because that's an age where we unfortunately do see cervical cancer as well. But what you were talking about there was a potential family history of colorectal and endometrial cancers, which we know are inherited together as a cancer predisposition syndrome called Lynch. And when a person has Lynch syndrome, they are at much increased risk, lifetime risk of endometrial cancer of up to 40 to 60%, depending on which gene they have their pathogenic variant in. So Lynch syndrome is caused by a pathogenic variant affecting one of the 4 mismatch repair genes, which are important for making sure when DNA copies, it does so properly and faithfully. And when that system is disrupted, then that increases the risk of colorectal cancer, endometrial cancer, ovarian cancer, and several other cancers. But endometrial cancer is the one that we see most often, obviously, in women. So when we have that kind of family history, it makes us a little bit concerned that they might have an underlying Lynch syndrome diagnosis.
And how many of the Lynch patients that you see actually know about it when they come in? Because I think that, I know that they're doing Lynch tests on colorectal cancers now, but if you had colorectal cancer 20 years ago, nobody was checking you for
Absolutely.
Lynch.
So Lynch syndrome is probably the commonest cancer predisposition syndrome that we have. It's supposed to affect about 1 in 300 people in the population, but I believe only 5% are aware that they have that diagnosis. So it's massively undiagnosed. And now that we are screening all colorectal cancers and endometrial cancers for markers of Lynch syndrome, we will start to find those family members who have got Lynch syndrome but not yet had a cancer themselves. So I think this will become more and more common that we know of people with Lynch syndrome who've not yet had a cancer diagnosis. And it's about how do we protect them, what cancer prevention interventions can we give them to prevent cancer, what surveillance do they need for the common cancers, and what index of suspicion do we need to have. So when they have particular symptoms, where are we fast tracking them for?
Yeah. So we need to be asked. So if we've got a patient like this, I suspect that the only thing out of all of that the patient would volunteer is that they've got irregular bleeding.
Yes, of course. So it's about thinking about what are the other factors that we need to be aware of. But of course, the benign causes of bleeding in that age group are far more common. So we do need to think about that. I believe if you're under the age of 50, then your risk of endometrial cancer when you have irregular bleeding is less than 1%, so 0.5%.
So if you've got a woman in her mid-40s with irregular bleeding who is normal weight and has no family history, then
it's the other causes that we're looking for first. Yes. But in the context of BMI, so if this person had a BMI of 30 or above, then that's a major risk factor. So we need to think about it in that.
So would you have a low threshold then for sending this patient for an ultrasound?
Yes, I would do.
Yeah,
so she has
with a
two
raised BMI.
She has 2 risk factors, doesn't she, that are
does.
important.
Yeah.
And is an ultrasound the right investigation, or do we need to do a suspected cancer referral?
Yeah, so that's difficult as well, isn't it? Because in a premenopausal woman, we're expecting natural cyclical fluctuation of the endometrium. So it's not going to be that good at diagnosing endometrial cancer unless it's in a polyp. So I think if they have a scan that finds an endometrial polyp, then we might be concerned that that could be a malignant endometrial polyp if they have Lynch syndrome. And so that would then be an urgent referral.
And what about if the ultrasound is normal? Can we be?
Yes, I think so. So the ultrasound scan that is normal, in other words, a thin endometrium in that age group of woman is very reassuring.
Right.
It's when it's thickened, but regularly thickened. It might just be stage of menstrual cycle. So then it's about whether we repeat the scan to see if it's become thin again.
Okay.
But if they have a polyp, I think we need to take the polyp seriously.
So if this woman's in her mid-40s and we send her for a scan and she's got a thin endometrium, then we can be reassured.
Yes.
If she's got a polyp, then that would presumably be reported and we would do something about that anyway. If she's got a thick endometrium, that isn't necessarily a reason to be alarmed, but it might be a reason to repeat. And it's difficult then to time repeating because people
Are
often
irregular.
got irregular cycles and you're thinking, oh.
Yes, of course. But I think if their symptom continues and a repeat scan shows another thickened endometrium, then they would be needing to be referred.
Okay,
Yes.
that makes sense. Thank you.
Okay, and I think it's just important also when we're taking the history and we're examining them to suss out where someone is bleeding from. And I know that might sound
Yes.
really a ridiculous thing to say, but particularly with the women's anatomy, they could bleed from 3 potential areas, front, middle or back. And I think it's important that we ask, is it hematuria? Is it vaginal bleeding or is it rectal bleeding? Because if they've actually just got staining in their underwear, they may not know.
Absolutely, they don't always know, and quite often there are urology referrals, and it's actually endometrial cancer, and vice versa.
Yes,
isn't it?
yes.
So,
When we did some work on hematuria and urological cancers, the women I spoke to, 2 out of the 3 of them had been referred on suspected gynae cancer referrals rather than urology. One of them said that she was absolutely certain that she didn't actually have vaginal bleeding. She was sure it was hematuria, but the GP thought she much more likely had vaginal bleeding. But they were, I think it's quite a common
It
issue.
is.
And presumably you're aware of that in your clinics as
Absolutely,
well. So,
yes.
you're not
swap.
sort of, sort of over.
Can you just tell us some other symptoms of endometrial cancer other than the bleeding that we may be alarmed about?
I mean, bleeding's the main one, and
Yeah.
it's not so much about the volume of bleeding, it's about the duration of bleeding. So have they had recurrent bleeding? That's more suspicious than a single episode, but not so much how much bleeding. But that's the main one, and we get that as our principal symptom in about 90% of endometrial cancers.
okay.
So that's the main one. If it's more advanced, obviously they can have associated pelvic pain, back pain, pressure symptoms.
What about vaginal discharge in older women?
That's also really important. So, particularly brown vaginal discharge, it's the same as postmenopausal bleeding as far as we're concerned. We take it just as seriously.
Right, okay. So that's because I think that there are probably a whole load of women who have recurrent thrush treatments.
Yes, absolutely. So it's about the colour of the discharge.
Yeah.
So brown discharge would be altered blood. So, those are the patients that we're worried about.
Yeah. And what about women who have persistent discharge and we've done swabs and they're negative?
I mean, that again could be, something benign. Could be related to being postmenopausal. They might benefit from vaginal estrogen.
So how they go, yeah.
But, if something is persistent and ongoing, then they do need to come through for a scan or for further assessment.
Yeah.
Sarah, I'm going to ask you a question now about LEGOC.
Yes, I like LEGOC.
You love an acronym.
Yeah, I do. And so endometrial cancer is one of the cancers that's included in LEGOC, which is cancers that are associated with new onset persistent raised platelets. So those will be lung, endometrial, gastroesophageal and colorectal. And we have just heard
Newsflash.
hot off the press that ovarian cancer should be included in that. So what we're suggesting...
So it's LEGOC.
LEGOC.
Like that,
yes.
yes.
LEGOC. I think what that really means is that... Because I think that some women don't necessarily mention postmenopausal bleeding. So if you've got somebody who's got new onset raised platelets and they stay, and you should actually specifically ask them about postmenopausal bleeding.
There's a lot of shame, isn't there, about
Yeah.
talking about that kind of thing.
Yeah.
But we absolutely need to ask the question.
Yeah. A few years ago, we had a patient who was in her 60s, I think, who had, she must have had some odd paraneoplastic syndrome because she kept having to sit down on the pavement when she was walking because she felt dizzy and unwell and weak. And I don't think she was particularly anemic, but she got to hospital. Because she became very unwell. And it took about a week in hospital before anybody specifically asked her about postmenopausal bleeding, and she had an endometrial sarcoma.
Oh, gosh.
And it was one of those really odd presentations, and it was only when somebody specifically asked about postmenopausal bleeding, because I think they'd asked her every question under the sun by this stage because nobody could work out what was the matter with her. She then had an ultrasound which showed that she had a sarcoma. I don't think at that point anybody even realised it was cancer related. I think there were sort of neurological diagnoses flying around and all sorts of things.
Wow. But yes, always ask the question.
Yeah. Yes.
Fantastic. So we're on to key clinical points. I think we've had a fantastic discussion. Would you like to start, Sarah?
Oh, goodness me. I think my first key clinical point would be that postmenopausal bleeding in a woman who is not on HRT is a red flag for referral.
Emma?
I think that postmenopausal bleeding is obviously something to refer urgently with suspected endometrial cancer, but we also need to think about whether they're up to date with cervical screening and whether it could be a cervical cancer. So an examination is also really important, just to have a look at the cervix.
So in addition to a really good history, a really good examination, also take a family history, which is really important, because and as part of the examination, do a BMI, because these are all risk factors for potential endometrial cancer. And I'm also going to say the Mounjaro one as well.
Yeah, and I was just going to add that actually if we can give some women some preparation for one-stop clinics and possible hysteroscopy, I think that would be beneficial.
Okay, and word of the podcast. Have we learnt anything that we'd like to include? Shall I start with you, Emma? Are you happy to do that?
I mean, we've talked a lot about HRT, unscheduled bleeding on HRT. It's a massive problem, isn't it?
Yeah.
And it's picking out the ones that need urgent referral
Yeah.
from those that don't.
Yeah.
So using the guidance as to who requires referral.
So is yours going to be HRT?
HRT.
There you go.
Well, I think because we've had something new, I'll go for LEGOC.
Ooh, LEGOC. And I'm going to go Lynch.
Yeah.
Because there's going to be more. We have a Lynch family in our surgery.
Oh, do you?
Yeah.
Yeah.
So I think
There'll be more of them.
There'll be going to be more.
Yes.
Okay.
Yeah, well, if you're saying
5% know that they have it.
Yeah.
Gosh, it's incredible.
And if they're now doing it as routine with all biopsies, etc.
Yes.
From, do you say colorectal endometrial?
Yes.
Yeah, we're going to be picking up more.
We will.
Well, thank you very much.
Thank you for having me.
This has been fascinating, and I hope you'll come on again and
Yes.
join us, and we want to hear more about your research.
Yes, I think so. Yeah.
So, final clinical point is our learning on Mounjaro or any of the GLP-1s, that people who are taking the oral progesterone component, GPs and primary care need to be aware to ask this, as it can cause a slowing down of the gastric emptying, which can reduce absorption of these medications, so a higher dose may be need to be used in these cases. So thank you for listening to GPs Talk Cancer from Gateway C. You can access our CPD accredited modules anytime via our website, and all reference studies and guidelines for this episode are linked in the show notes. If you'd like to submit a question for any of our to be recorded episodes, please make sure you sign up to our Gateway C mailing list. The link is in the show notes and you'll receive a survey link. Alternatively, please email your thoughts or questions to the christy.gatewayc@nhs.net. A big thank you to Emma and to our producers from Gateway C and Listening Dog Media. If you haven't already, please follow the podcast so new episodes can drop straight into your feed. And if you think a colleague would find this episode helpful, we'd really appreciate you sharing it. It helps us reach more primary care health professionals. Thank you for joining us, and we'll be back again soon.